Assalamualaikum everyone, and good evening to today's PSA Karachi Online Lecture Series. Today we welcome Dr. Mujahid Islam. Dr. Islam currently serves as Professor and Head of Department of Anesthesiology at Rahman Medical Institute and Rahman Medical College, Peshawar. He also serves the position as Supervisor in Anesthesiology and Cardiothoracic Anesthesia with the College of Physician Surgeons, Pakistan, and also the Vice President of PSA KPK. Before we begin, I request the participants to kindly mute their mics and use the chat box to share their questions during the lecture. Your queries will be addressed post-lecture. Up to you, Dr. Mujahid.
Thank you, Dr. Abdullah. Assalamu alaikum, everyone, and thank you for joining. Can everyone hear me clearly and see my screen?
Yes, sir, your voice is visible, sir.
Okay. I'm honored to speak today on enhanced recovery associated with neurosurgical procedures. I would like to begin by sincerely thanking the Pakistan Society of Anesthesiologists Karachi chapter for their outstanding efforts in promoting high-quality online academic activities. Their commitment has significantly contributed to the professional growth of anesthesiologists across Pakistan and beyond, fostering global collaboration, knowledge sharing, and continuous improvement in our specialty. And a big round of applause for PSA Karachi, and a special thank you to Dr. Asma for giving me this opportunity. I have no conflict of interest to declare for this educational activity. Today's presentation will follow a structured roadmap to guide our understanding of enhanced recovery after surgery, ERAS, in neurosurgical procedures. We will begin by exploring the significance of variation in clinical practices, particularly how inconsistent perioperative care contributes to unpredictable outcomes and increased healthcare burden, highlighting why ERAS standardization matters. Next, we will define what ERAS is, its core principles and goals, like improving recovery, reducing complications, and shortening hospital stay. We will also touch upon key risks associated with prolonged hospitalization, such as nosocomial infections, deconditioning, and delayed return to baseline function. I will then walk you through a generic ERAS protocol, focusing on evidence-based strategies across the preoperative, intraoperative, and postoperative phases. We will look at the key role of different international societies like the ERAS Society and American Society of Enhanced Recovery in shaping and implementing ERAS across specialties and regions. Then we will discuss ERAS as applied to lumbar spinal fusion, where significant progress has been made, providing insights and groundwork for neurological ERAS. After that, we will examine proposed core components of ERAS for craniotomy based on current literature and emerging data, showing how it's beginning to transform elective cranial surgery outcomes. And no discussion would be complete without acknowledging the barriers and challenges to ERAS implementation, especially in neurosurgery. Wait a minute. Neurosurgery. And we will wrap up with a summary of key takeaways and conclusions, followed by question and answers. Okay, this was the roadmap. When two patients with similar demographic profiles and nearly identical comorbidities undergo the same surgery, but in different institutions or under different clinical teams within the same hospital, their outcomes can vary significantly. This includes differences in length of hospital stay, complication rates, and recovery trajectories. Why does this variation exist? As Dr. W. Edwards famously said, uncontrolled variation is the enemy of quality. This principle is extremely important in healthcare, particularly in surgery, where inconsistent practices can compromise patient safety and lead to suboptimal outcomes. A landmark study by Cohen and colleagues published in the Annals of Surgery analyzed data from 182 hospitals participating in the NSQIP program. The study found considerable variation in hospital length of stay following colorectal surgery, even among patients with comparable demographics and health status. So, what accounted for the difference? The hospitals that achieved shorter and more consistent lengths of stay were those that implemented clear, standardized, evidence-based protocols. It wasn't random, it wasn't luck, it was about structure, systems, and team coordination. The takeaway is clear. To provide safer, high quality care, we must reduce unnecessary variation and adopt consistent evidence-based across the board. So this is where the concept of ERAS comes in. ERAS is not about discovering new knowledge. It's about applying what we already know in a consistent and integrated way throughout perioperative period. As healthcare professionals, it's our responsibility to ensure that every patient receives the highest standard of care every time without exception. So enhanced recovery after surgery, also referred to as enhanced recovery pathways or fast track programs, are evidence-based, multimodal, and multidisciplinary protocols designed to optimize perioperative care and improve recovery outcomes for surgical patients. Let me repeat it again. ERAS are evidence-based, multimodal, and multidisciplinary protocols designed to optimize perioperative care and recovery outcomes for surgical patients. So let's go over the core principles of ERAS. These are what make the program so effective. First, multidisciplinary teamwork. ERAS only works when everyone is on the same page. Surgeons, anesthesiologists, nurses, physiotherapists, dietitians, and many more. It's a team effort from start to finish. Second, evidence-based interventions. This isn't about doing what we have always done. It's about using proven, research-backed strategies that improve outcomes and speed up recovery. Third, patient engagement. Patients are not just passive recipients of care. We educate and involve them early so they understand what to expect and how they can actively contribute to their own recovery. And finally, continuous audits. ERAS includes built-in tracking systems to monitor how well we are sticking to the protocols. This helps us identify gaps, make improvements, and maintain high standard of care. Let's take a look at the key goals of ERAS. First, minimizing the surgical stress response. Surgery triggers a stress reaction in the body. ERAS aims to blunt that through careful anesthetic, fluid, and metabolic management. Second, reducing end organ dysfunction. By keeping the body in better balance during and after surgery, we lower the risk of organ-related complications, especially in high-risk patients. Third, optimal control of postoperative pain. ERAS emphasizes multimodal analgesia, using different methods together to reduce reliance on opioids and improve patient comfort. Fourth, expediting recovery. From early mobilization to quicker return of gut function, every ERAS step is designed to get patients back to normal life faster. Fifth, decreasing hospital length of stay. When we reduce complications and support faster recovery, patients go home sooner, and that's better for them and for the healthcare system. And finally, reducing complications. All of this adds up to fewer infections, fewer readmissions, and better overall outcomes. Now let's talk about why prolonged hospital stays can be dangerous, not just inconvenient, but actually harmful to patients. First, fasting and malnutrition. Extended fasting leads to malnutrition, which weakens the immune system and increase the risk of infections. It also linked to longer hospital stays and higher mortality. Second, sleep disruption. Hospitals are noisy and disruptive, especially at night. Poor sleep contributes to ICU delirium and also delays wound healing, two major concerns in surgical recovery. Third, immobility. Patients who stay in bed for more than 3 days are at high risk for DVTs and pressure ulcers. These can lead to serious infections and even death if not managed early. Fourth, medication errors. These are more common the longer a patient stays in the hospital. In the US, medication errors cause over 7,000 deaths each year and harm more than 1.3 million people. And finally, medical errors overall. Prolonged stays increase exposure to multiple care teams and intervention. Medical errors have now become the third leading cause of death in the US, with up to 98,000 preventable deaths every year. And this was the data of 2016. Maybe it is much more at the moment. And all of this underscores why ERAS is so important. It's not just about faster recovery, it's about avoiding the risks that come with unnecessary hospital time. Now let's discuss a generic protocol for ERAS, which can be applied to almost all types of surgery with some fine-tuning. Let's walk through the key preoperative strategies used in ERAS. These aim to optimize the patient before surgery and reduce post-operative complication. First, patient evaluation and education. We start with a thorough assessment of comorbid conditions and make sure the patient and family understand the care plan. Rehabilitation, if appropriate. This may include smoking cessation, nutritional support, physical exercise programs, cognitive training, and stress reduction techniques. These help improve overall resilience before surgery. Patient and family education is vital. Informed patients are more engaged and recover better. This also supports shared decision making, aligning treatment goals with patient preferences. Preoperative fasting protocols have changed. Clear fluids are now allowed up to 2 hours before surgery, and carbohydrate-rich drinks can be given to reduce insulin resistance. Solid food and milk should be stopped 6 hours prior. Preoperative medication include multimodal opioid-sparing analgesia. This helps control pain early and reduce reliance on opioids postoperatively. Antibiotic prophylaxis is essential. Give antibiotics within 60 minutes before incision. And don't forget to assess for risk in all 4 major infection areas, which are urinary tract infections, surgical site infections, pneumonia or aspiration, and line-associated infections. Finally, venous thromboembolism prophylaxis must be initiated based on individual risk. This can significantly reduce preventable postoperative complications. All these steps are designed to set the patient up for the best possible outcome before the first incision is even made. Now let's move on to intraoperative strategies in ERAS, which are all about minimizing surgical stress and supporting faster recovery. Minimally invasive surgery is preferred wherever possible. Using smaller or transverse incisions can reduce pain, complications, and recovery time. Avoiding routine use of NG tubes, wound drains, urinary catheters, and CVP lines helps promote early mobility and lowers infection risk. Use them only when absolutely necessary. Anesthetic techniques are critical. We aim to use short-acting anesthetics, and analgesic agents, as well as short-acting neuromuscular blockers to allow quicker emergence and recovery. Multimodal analgesia is the cornerstone of ERAS. This includes reducing total opioid use, preferential use of short-acting opioids, selective and minimal use of long-acting opioids. Antiemetic prophylaxis is also essential to reduce post-operative nausea and vomiting. Dexamethasone 8 to 10 milligram IV after induction, ondansetron 4 milligram IV at the end of surgery. And for high-risk patients, consider a third agent like scopolamine and/or use TIVA. Lung protective ventilation by using low tidal volumes and avoiding high pressures helps prevent pulmonary complications. Intraoperative fluid management should be goal-directed to avoid both overload and hypovolemia. Body temperature control is important. Keep the patient normothermic to reduce infection and bleeding risks. Finally, glycemic control. Maintain blood glucose in a safe range, even in non-diabetics, as hyperglycemia is linked to poor wound healing and higher infection rates. All of these strategies work together to reduce surgical stress and promote smoother recoveries. Now let's now review the post-operative strategies that enhance recovery and minimize complication. Multimodal pain management is essential. This includes the use of various pharmacological agents along with local or regional anesthetic techniques to improve pain control and reduce opioid use. Post-operative nausea and vomiting should be actively managed, especially in high-risk patients, to support early feeding and mobilization. Fluid management in the post-operative phase should be goal-directed, avoiding both overload and under-resuscitation to maintain optimal recovery condition. Early oral feeding is recommended, ideally within hours of surgery, to stimulate gut function, reduce infection risk, and support healing. Early mobilization, including sitting up and walking within the first 24 hours, can help prevent complications like DVT, pneumonia, and deconditioning. Early removal of urinary catheters and surgical drains supports infection prevention and encourage return to normal activity. Together, these strategies support faster recovery, lower complication rates, and shorter hospital stay. So the Enhanced Recovery After Surgery Society, or ERAS Society, was founded to advance perioperative care and improve patient recovery through research, education, audit, and the implementation of evidence-based practices. Its origin traced back to the ERAS study group formed by leading European experts to build upon Professor Henrik Kellert's concept of multimodal surgical care. Early findings revealed significant variation in clinical practice and a gap between traditional methods and best evidence, promoting efforts to drive systemic change. Key milestones include the first ERAS symposium in 2003, the publication of the first evidence-based consensus protocol for colonic surgery in 2005, and studies emphasizing the need for structured implementation strategies. In 2010, the ERAS study was officially established in Stockholm as a non-profit organization, with its founding members playing a pivotal role in promoting standardized, evidence-based perioperative care worldwide. And the American Society for Enhanced Recovery, founded in 2014, plays a key role in promoting ERAS principles in North America. While it works closely with the ERAS Society, it has its own leadership and regional focus to address the unique needs of the US healthcare system. As of now, the ERAS Society has not officially published guidelines specifically for enhanced recovery after surgery in neurosurgery, except for lumbar spine fusion. However, enhanced recovery principles are increasingly being applied in neurosurgical practice, with multiple expert consensus statements and institutional protocols emerging globally based on ERAS principle. So the enhanced recovery is, according to American Society of Enhanced Recovery Pathways, is based on 4 key principles, and all must be in place for an effective program. First, the patient should be an active partner in their care. Second, they must be in the best possible health before surgery. Third, care during and after surgery should follow evidence-based practices that reduce harm. Finally, recovery should focus on helping the patient return to normal life as soon as possible. Achieving this requires a committed, coordinated effort from the entire healthcare system. So these are the 4 basic principles of ASER. Now we come to this review article developed by a multidisciplinary group under the ERAS Society, presents evidence-based guidelines for enhanced recovery in lumbar fusion surgery. A total of 256 articles were reviewed to develop consensus statements for 22 ERAS items. One item, prehabilitation, was excluded from the final summary due to very poor quality and conflicting evidence in lumbar spinal fusion. From the remaining 21 ERAS items, 28 recommendations were formulated. All recommendations are based on the best possible evidence. This slide summarizes key areas for preoperative optimization. We focus on patient education. These are the preoperative recommendation by ERAS Society for lumbar spinal fusion surgery. Okay, so this slide summarizes key areas for preoperative optimization. We focus on patient education and counseling to reduce anxiety and improve cooperation. Nutritional assessment is important, especially for high-risk or malnourished patients, and supplements may be needed. We advise stopping smoking and alcohol well before surgery and correcting anemia early. Patients should be allowed clear fluids up to 2 hours before anesthesia to improve comfort and reduce insulin resistance. Finally, medications should be reviewed and adjusted as needed to ensure the patient is stable and optimized for anesthesia and surgery. This slide highlights key intraoperative strategies aimed at minimizing surgical stress and enhancing recovery. We start with timely administration of broad-spectrum antibiotics to prevent infections. Standard anesthesia techniques help ensure stability while maintaining normothermia, reduces complications like bleeding and wound infections. Using local anesthetics and multimodal opioid-sparing analgesia helps control pain effectively with fewer side effects. Proper fluid management and post-op nausea vomiting prevention are also essential for smooth recovery. Minimally invasive approaches, limiting the use of drains and urinary catheters, and ensuring appropriate antithrombotic prophylaxis all contribute to reduce surgical stress and supporting early post-operative recovery. This slide outlines key post-operative strategies focused on early recovery and return to normal functions. Encouraging early mobilization and starting physical therapy as soon as possible helps reduce complications and speeds up recovery. Pain should be managed using multimodal opioid-sparing techniques to minimize side effects. Preventing post-op nausea vomiting, maintaining optimal fluid balance, and starting early oral nutrition are all crucial for enhancing comfort and promote healing. Antithrombotic prophylaxis must continue to reduce the risk of blood clots. Finally, regular perioperative audits help ensure protocol compliance and allow us to monitor outcomes and continuously improve care. So now we are done with generic ERAS protocols and ERAS for lumbar spinal fusion surgery. Now we come to a proposed core components of ERAS for craniotomy. So Dr. Fraz represented Pakistan in this important global review on use of ERAS protocols for craniotomy. Experts from 26 countries contributed their experiences, highlighting how ERAS is being implemented across various healthcare systems. This review identifies current practices, gaps in knowledge, and key areas for improvement. It offers a comprehensive global perspective on ERAS in neurosurgery and outlines proposed core components specifically tailored for craniotomy, which we will discuss in detail in the upcoming slides. These are the proposed strategies for craniotomy. So in the preoperative phase, key ERAS components include patient education and counseling, optimization of comorbidities, and assessment of nutritional status, frailty, and cognitive function. Rehabilitation along with smoking and alcohol cessation at least 4 weeks prior to surgery and DVT prophylaxis when indicated are also recommended. Patients should adhere to shorter fasting protocols, allowing clear fluids up to 2 hours before induction. Routine use of sedatives should be avoided to minimize unnecessary sedation. And now I will discuss a few components of preoperative strategies, as covering each one in detail is beyond the scope of this presentation. Patient education can be delivered in various ways. This includes preoperative classroom sessions, web-based modules and classes, information pamphlets, educational videos, verbal explanations, and even text messaging to reinforce important information. Carbohydrate loading before surgery helps reduce insulin resistance, preserve muscle, improve how comfortable patients feel, and speeds of recovery. Patients should drink 800 ml of a 12.5% carbohydrate solution the night before surgery, then 400 ml about 2 to 3 hours before anesthesia. Carbohydrate loading is suitable for most elective surgery patients but should be avoided or used carefully in patients with poorly controlled diabetes, delayed gastric emptying, emergency surgeries, or high risk for aspiration like severe GRD. So anemia is defined by the WHO as hemoglobin less than 13 in men, less than 12 in women, and less than 11 in parturients. It should be checked in all patients undergoing surgery with expected blood loss over 500 ml. When treating anemia before surgery, the goal is to raise hemoglobin to at least 13 gram per deciliter in both men and women to reduce the need for blood transfusions in perioperative period. About 30 to 50% of surgical patients are anemic. Early screening, ideally 4 to 6 weeks before surgery, is important. We need to find and treat the underlying causes, optimize RN therapy, and work to minimize blood loss during surgery. A multidisciplinary approach is key for effective management and better patient outcomes. Based on our 4 years of experience with over 2,000 patients, we have observed that patients presenting with preoperative anemia who undergo CABG are more likely to experience comorbidities and mortality after the surgery. In short, mortality is doubled in anemic patients as compared to non-anemic patients. And similarly, in more than 500 valvular patients who went for valve replacement have mortality in anemic patients of almost 3.2% as compared to 1.8% in non-anemic patients. So now let us talk about the nutritional status. And this important consensus by Wishmer et al. Stresses the vital role of nutrition in surgical recovery and recommends making nutritional care a core part of ERAS pathways. It introduces the perioperative nutrition screen tool for early identification of patient at risk of malnutrition, something that's often overlooked but is linked to higher complication rates, longer hospital stays, and increased cost. The author emphasized that early screening and timely nutritional support can significantly improve outcomes. They also advocate for a team-based approach involving surgeons, anesthesiologists, and dietitians to ensure that nutrition is properly addressed throughout the perioperative period. So, when a patient comes to a preoperative anesthesia assessment clinic, the first step is to check for the BMI. If it is less than 18.5 or age is less than 20 or age is more than 65, and if there is an unplanned weight loss of more than 10% in past 6 months, or if there is 50% reduction of normal diet in the last week, if there is any yes to above 3 or albumin is less than 3, then one should send these patients to pre-op nutrition clinic or dietitian for dietitian intervention. So let's come to the intraoperative strategies. Anesthetic management must minimize brain swelling and allow rapid awakening in the intraoperative phase. We focus on minimizing physiological stress and promoting faster recovery. Short-acting anesthetics and goal-directed fluid therapy help maintain hemodynamic stability. Multimodal analgesia like acetaminophen and dexmedetomidine reduces reliance on opioids. Maintaining normothermia is crucial to prevent complications from hypothermia. We also aim for minimally invasive surgical approaches using tools like neuronavigation and electrophysiologic monitoring, local anesthetic techniques, post-op nausea vomiting prophylaxis, and early removal of urinary catheters all support quicker recovery. Extubating patients in the OR and avoiding ICU stays when safe are also key ERAS targets for neurochecks. All right. Okay. Scalp nerve block. Scalp nerve block, now we are discussing multimodal analgesia, and scalp nerve block is a regional anesthetic technique used to block the sensory nerves of the scalp, providing effective perioperative analgesia for various cranial procedures. It targets 6 pairs of nerve, 4 branches of the trigeminal nerve for the anterior and lateral scalp block, including the supratrochlear, supraorbital, zygomaticotemporal, and auriculotemporal, and the 2 branches from the cervical plexus for the posterior scalp block, the greater occipital and the lesser occipital. Common indications include awake craniotomies under general anesthesia for intraoperative and postoperative analgesia, and management of scalp lacerations or minor cranial procedures. Traditionally, scalp nerve blocks are performed using landmark-based techniques that rely on surface anatomy and palpation, but these can be less precise in patients with atypical anatomy. In contrast, ultrasound-guided scalp blocks offer real-time visualization, enhancing accuracy, safety, and overall block quality. While both approaches aim to anesthetize the same 6 nerve pairs on each side of the scalp, ultrasound guidance represents a valuable advancement in modern neurosurgical anesthesia. I will discuss ultrasound scalp blocks in more detail in the upcoming slides. So, this narrative review by Paul et al. Highlights the advantages of using ultrasound guidance for scalp nerve blocks in neurosurgery. Ultrasound guidance allows for more accurate nerve localization using small volumes of local anesthetic, typically 2 to 3 ml per nerve, reducing the risk of toxicity and minimizing complications like vascular puncture, as nearby arteries can be identified using color Doppler. This is particularly useful given the anatomical variability in nerve pathways and foramina. These images show ultrasound-guided scalp nerve blocks. It will be difficult for me to discuss them all in detail due to time constraints, but I wanted to share them to highlight that ultrasound-guided scalp block is gaining popularity and is likely to become a standard practice soon, especially as ultrasound is now widely used across many areas of anesthesia. So the scalp nerve block plays a significant role in multimodal anesthesia for neurosurgical procedures. It helps reduce intraoperative opioid requirements, contributing to opioid sparing strategies, which are particularly important in neurosurgery where excessive sedation or respiratory depression must be avoided. By blunting nociceptive input, the block helps stabilize hemodynamics during painful stimuli such as scalp incision and head pin placement, which are otherwise associated with sudden increase in heart rate and blood pressure. Overall, this contributes to enhanced recovery and greater patient comfort, both intraoperatively and postoperatively. Potential complications of scalp block may include hematoma formation, particularly in vascular areas, local anesthetic systemic toxicity if high volumes or concentrations are used, or if inadvertent intravascular injection occurs. There is also a small risk of nerve injury, and the block may occasionally fail due to inaccurate placement or anatomical variations. So in conclusion, the scalp block is a safe, effective, and low-risk component of multimodal anesthesia in neurosurgery. A bilateral approach is generally required, and the use of ultrasound guidance is increasingly preferred due to improved accuracy and safety. Incorporating training in ultrasound-guided techniques can further enhance success rates and minimize the risk for complications, making it an essential skill in modern neurosurgical anesthetic practice. So regarding the choice between TIVA and balanced inhalational anesthesia, a study by Evrian et al. Published in the Journal of Clinical Medicine in 2015 compared these two techniques in patients undergoing supratentorial craniotomy. The key findings was that both approaches were equally effective in terms of early postoperative recovery markers, such as time to extubation, eye opening, response to commands, and achieving an adequate RDID score. This supports the flexibility of choosing either anesthetic technique based on patient characteristics, surgical context, and provider preference without compromising the quality of recovery. The use of dexmedetomidine, or in short DEX, in neurosurgical practice is now well established and offers several advantages. DEX is a selective alpha-2 adrenergic agonist known for its sedative, anxiolytic, analgesic, and sympatholytic properties. Clinically, it provides key benefits such as neuroprotection, hemodynamic stability, minimal respiratory depression, and reduced opioid requirements. It is particularly useful in awake craniotomies, neurocritical care, and pediatric or spine surgeries. However, it is not without concerns. Bradycardia, hypotension, and limited data on long-term neuroprotection remain areas of caution. The takeaway: DEX is a versatile adjunct, but dosing must be individualized and closely monitored. DEX is increasingly recognized not just as a sedative, but as a drug with multiple neuroprotective benefits in the perioperative setting. Studies have shown that DEX possesses anti-inflammatory and anti-delirium properties and may help preserve cognitive function following anesthesia. One of its unique mechanisms is the reduction of brain noradrenergic activity, which enhances the lymphatic system, which is basically the lymphatic system of this brain, and the brain's waste clearance pathways, facilitating the removal of harmful peptides. Additionally, animal studies have shown that DEX reduces both cerebral blood flow and metabolic demand, thereby maintaining a balance between oxygen and glucose supply and consumption. These properties make DEX a valuable neuroprotective agent, especially in neurosurgical patients. This slide summarizes findings from a systemic review and meta-analysis by Wang et al. published in the Journal of Clinical Anesthesia in 2019, which evaluated the use of DEX during craniotomy under general anesthesia. The review found that DEX significantly reduces post-operative pain and the incidence of post-op nausea vomiting, both important ERAS goals. It also helps stabilize hemodynamics by reducing hypertension and tachycardia without significantly increasing the risk of hypotension or bradycardia. However, in terms of procedural success, DEX showed no major advantage compared to placebo or other anesthetics. Importantly, the authors noted that more research is needed to assess its long-term effects and direct comparisons with other anesthetic agents. Effective perioperative fluid management is a key component of ERAS protocols. Studies have shown that optimizing fluid balance can reduce complications and shorten hospital stays. The primary goal is to maintain euvolemia, avoiding both dehydration and fluid overload. The choice between balanced crystalloids and normal saline remains a subject of ongoing debate. However, excess salt and water should be strictly avoided. Intraoperatively, goal-directed therapy involving tailored fluid and inotropes administration helps optimize cerebral perfusion, which is especially critical during neurosurgery. This approach ensures adequate oxygen delivery while minimizing the risk of edema and delayed recovery. The choice between normal saline and balanced crystalloids remains an ongoing debate, as I already said, with the literature showing mixed results. Recent trials evaluating intravenous fluid choices in critically ill patients have reported varying outcomes. The PLUS and BASIC trials found no significant difference in long-term mortality between balanced crystalloids, for example, plasma light and 0.9% normal saline. In contrast, the SMART and SALTED trials reported reduced short-term kidney injury and improved composite renal outcomes with the use of balanced crystalloids. Overall, balanced fluids may offer renal benefits without a significant impact on long-term mortality. So, according to 2022 Neurocritical Care Society guidelines, isotonic crystalloids such as normal saline or balanced solutions are recommended to maintain serum osmolarity, while hypotonic fluids like 0.45% normal saline are strongly discouraged due to risk of exacerbating cerebral edema. The Brain Trauma Foundation guidelines prefer the use of normal saline or hypertonic saline in patients with traumatic brain injury, largely based on historical use and clinicians' familiarity, though they do not explicitly discourage balanced fluids as long as serum chloride is carefully monitored. For general ICU care, the Society of Critical Care Medicine and European Society of Intensive Care Medicine recommend balanced crystalloids, but they caution against extrapolating these findings to neurocritical care without further evidence. In elective neurosurgery without raised ICP, balanced fluids, especially plasma light which lacks lactate, are increasingly used and considered safe, though normal saline remains common due to institutional habits. In summary, normal saline remains the fluid of choice in neuroanesthesia, particularly for traumatic brain injury patients. Lung protective ventilation is increasingly being used during craniotomy to minimize ventilator-associated lung injury. A key benefit is that it does not significantly affect hemodynamics, which is crucial in neurosurgical patients. Lung protective ventilation has also been shown to reduce both localized and systemic inflammation, as well as oxidative stress by basically reducing atelectatic trauma, volute trauma, barotrauma, and finally the biotrauma. And these benefits make it especially valuable for high-risk patients or those undergoing prolonged anesthesia. A 2017 bi-center randomized trial by Tang et al. Supports the use of lung protective ventilation in neurosurgery, highlighting its role in enhancing post-operative outcomes without compromising cerebral perfusion. Train trial Train trial is a multi-center RCT published in JAMA 2024. Compare restrictive versus liberal transfusion strategies in 72 ICUs across 22 countries. Patients with acute brain injury and anemia were randomized to either a liberal strategy, transfusion at hemoglobin 9 or less, or restrictive strategy with a hemoglobin of less than 7. The study found that the liberal transfusion group had a significantly lower probability of unfavorable neurological outcomes at 180 days compared to the restrictive group. These results suggest that maintaining higher hemoglobin levels may improve long-term neurological recovery in this vulnerable population, challenging traditional restrictive transfusion practices in neurocritical care. The Hemotion trial 2024 compared liberal in their trial they target the hemoglobin of 10 or less versus restrictive of hemoglobin 7 or less transfusion strategies in 34 centers across Canada, Europe, and Brazil for moderate to severe traumatic brain injury patients. Contrary to previous findings, this RCD found no significant difference in 6-month GCS scale after 6 months. These results suggest that maintaining high hemoglobin levels through liberal transfusion may not improve long-term neurological outcome in traumatic brain patients, supporting current restrictive transfusion practices for this specific population. So the data is mixed for transfusion strategies, but I will prefer 9 gram per deciliter for traumatic brain injury patients. Okay, now come to the emergence. Emergence from general anesthesia is a critical period that can trigger several physiological stress responses. This includes sympathetic nervous system activation leading to increased cerebral metabolic rate of oxygen, hypertension, tachycardia, and hypoventilation. Patient may also experience shivering, pain, and hyperglycemia, all of which can negatively affect recovery, particularly after neurosurgery. It's essential to proactively manage and prevent these responses through tailored anesthesia techniques, adequate analgesia, temperature control, and careful hemodynamic monitoring to ensure a smooth and safer emergence. Maintaining key physiological parameters within normal ranges is critical during neurosurgery, though sometimes it is difficult, especially toward the end of the procedure to ensure optimal brain protection and recovery. We aim for normothermia to avoid the adverse effects of both hypothermia and hyperthermia. Normovolemia and normotension supports stable cerebral perfusion. Normocapnia helps regulate intracranial pressure, while normosmolarity and normoglycemia are essential for cellular function and brain metabolism. Ensuring normal coagulation minimizes the risk of bleeding, and maintaining hemoglobin levels at or above 9 gram per deciliter ensures adequate oxygen delivery. Collectively, these targets help reduce complications and promote enhanced recovery. Several factors can increase the risk of delayed or failed extubation for craniotomy: age over 65 years, ASA status greater than 2, preoperative GCS less than 13, emergency surgeries, anesthetic time over 5 hours, intraoperative blood loss of more than 700 ml, use of cerebral protective techniques, total propofol dose of more than 1000 milligram while using TIVA, total fentanyl dosage of more than 50 microgram per hour, and completed operation time after 4 p.m. Now come to the post-operative phase. In the post-operative phase of enhanced recovery after surgery, a multidisciplinary approach remains essential to ensure optimal outcomes. Effective multimodal analgesia should be implemented combining non-opioid agents such as acetaminophen and NSAIDs to minimize opioid use and associated side effects. Post-operative nausea vomiting prevention should be proactively addressed. Drains should be removed early. Initiating oral nutrition as soon as clinically feasible enhances gut function and recovery. Thromboprophylaxis tailored to patient risk is critical. Early mobilization, ideally on the day of surgery or shortly thereafter, along with an in-hospital physical therapy, plays a key role. Delirium prevention strategies um, and discharge should be guided by standardized criteria to ensure safe and timely transition out of the hospital. Finally, continuous quality improvement through data audit and regular multidisciplinary review is vital to sustain and refine enhanced recovery practices. So, what is the current evidence for enhanced recovery after surgery protocols in craniotomy? In the Wang et al. 2018 randomized controlled trial on ERAS for after elective craniotomy, significant in the control group, pain outcomes were better with 79% of ERAS patients reporting only mild pain on post-operative day 1 compared to 33% in controls. And overall pain duration was significantly shorter. Early recovery markers were also improved. 74% had urinary catheters removed within 6 hours, and oral liquid and solid food intake resumed significantly earlier, 8 and 24 hours respectively, versus 11 and 72 hours in the control group. Importantly, there were no 30-day readmissions or reoperations in either group, underscoring the safety of the protocol. The same research group further identified that implementation of the ERAS protocol led to a significant reduction in postoperative pain scores, length of hospital stay, and overall hospitalization costs. Importantly, these improvements were achieved without any increase in postoperative complications, reinforcing both the safety and cost effectiveness of ERAS protocols in neurosurgical patients. This quality improvement study from NYU Grossman School of Medicine evaluated the development and implementation of an ERAS after cranial surgery pathway for patients undergo elective supratentorial tumor resection. So this protocol targeted early discharge by post-operative day 2 and was compared against standard and historical care cohorts. Among 188 eligible patients, those enrolled in the ERAS after cranial surgery pathway had a significantly shorter median hospital stay, 1.93 days versus nearly 3 days in the control groups, and reduced ICU utilization. And importantly, there were no significant differences in 30-day emergency visits, readmissions, or complication across the group. And these findings support the safety and efficacy of enhanced recovery after cranial surgery in reducing resource utilization without compromising patient outcomes, reinforcing the feasibility of implementing accelerated recovery pathways in selected neurosurgical patients. There is another study published in BMJ Open evaluated patient satisfaction with the neurosurgical ERAS program for elective craniotomies through both quantitative and qualitative analysis, and the results showed that mean patient satisfaction scores were significantly higher in the ERAS group at the time of discharge compared to the control group. This 2021 non-randomized controlled trial published in BMC Neurology assessed the impact of ERAS in elective craniotomies. 70 patients were included, and the study found several significant improvements in the ERAS group. Notably, a greater proportion of ERAS patients stayed in the ICU for less than 48 hours post-operatively. Most recently, a 2024 systemic review and meta-analysis by Kim et al. Found that ERAS protocols for craniotomy are associated with reduced length of stay and lower risk of post-op nausea, vomiting, and post-operative pain. So in Pakistan, There are currently no formally established ERAS protocols for patients undergoing craniotomies. While elements like minimizing fasting, preoperative scalp blocks, and multimodal analgesia are occasionally used, they are not structured within a comprehensive ERAS framework. Neuroanesthesia is still not widely recognized as a subspecialty in many healthcare centers, which contributes to limited awareness and inconsistent application of ERAS principles. However, there are some encouraging developments. For instance, AKUH Khan University Hospital has initiated a similar enhanced recovery protocol specifically for awake supratentorial craniotomies. This reflects growing recognition of the benefits of ERAS in neurosurgical care, though widespread implementation remains a challenge. Okay, now the following challenges were identified by the Donato et al. In their landmark review and are also highly relevant for low and middle income countries, including Pakistan. And these should be seriously considered when initiating an ERAS program in any specialty, particularly neurosurgery. A primary challenge is the widespread lack of knowledge and familiarity with ERAS principles among healthcare providers, compounded by limited training in neuroanesthesiology. Multidisciplinary collaboration, critical for ERAS success, is often insufficient or fragmented. There is significant regional disparities further hindering uniform implementation, as do variations in reimbursement structures that may disincentivize protocol adoption. Additionally, outdated surgical practices persist in many institutions, especially where change is resisted or protocols are not regularly updated. There is also a notable gap between academic and private practice environments. Academic centers are more likely to adopt ERAS, while private setups often lag behind. These combined factors create a complex landscape that requires coordinated efforts and systemic change for effective ERAS integration in neurosurgical care. So, what are the takeaways? And this slide summarizes the key messages from our today's presentation. First, we discovered how variation in clinical practices, especially in perioperative care, can negatively impact patient outcomes and lead to longer hospital stays and complications. ERAS helps mitigate this by promoting standardization and consistency. Second, we covered the definition and core goals of ERAS. It's a multimodal, evidence-based approach aiming to improve functional recovery, reduce complications, shorten hospital length of stay, and enhance patient satisfaction. Third, we emphasized the importance of following a structured protocol across the preoperative, intraoperative, and postoperative phases. Each phase has targeted strategies that, when implemented as a bundle, can significantly improve outcomes. Next, we looked at how various international societies like ERAS Society and American Society of Enhanced Recovery are instrumental in promoting, developing, and adapting ERAS protocols across surgical specialties and regions. We also examined ERAS in lumbar spinal fusion, which has seen significant progress. The success in spinal surgery demonstrates the feasibility and impact of ERAS principles and serves as a model for application in cranial neurosurgery. For craniotomy-specific ERAS, emerging data support benefits like early ambulation, improved pain control, faster return to oral intake, and reduced ICU utilization, all with no increase in complications. Finally, we acknowledged key challenges in implementing ERAS in neurosurgery, like the lack of specialized neuroanesthesia training, limited interdisciplinary coordination, regional disparities, and outdated surgical practices. Recognizing these barriers is the first step toward overcoming them. Together, these takeaways reinforce the value, feasibility, and future potential of ERAS in surgical care. Thank you.
Thank you, Dr. Mujahid. Not only did we learn new about ERAS, it was such a holistic view with regards to the neuroanesthesia services and such a fitting culmination to the lecture series. I'd like to invite the participants to put on their questions in the chat box if there are any, which can be addressed by Dr. Mujahid himself. Well, since we are also short on time and there are not much questions, I'd like to request Dr. Faraz Shafiq to have some closing remarks with regards to ERAS in neuroanesthesia.
Thank you, Abdullah, and thank you, Dr. Mujahid, for a wonderful presentation. So, by looking at and by listening to your presentation, it reminded me those days when you were my chief resident. And I must say, you are still the same great teacher, Alhamdulillah. And besides, these remarks, so it's very important that you have discussed all the things which were relevant and the need of the time. So yes, similarly, the IRAS is the need of time for us for the neurosurgical patients in Pakistan because the outcome of these patients really matters. What we as an anesthetist do intraoperatively, and this all has to do something with cerebral hemodynamics and maintaining autoregulation and intracranial pressure. So I think you have mentioned all the things wonderfully. So I have nothing to say, on the expert content wise because you have covered all the things. So that was all from my side. And yes, it's very important for us to implement the management protocols for which we have to overcome on the heterogeneity. And we need to develop the protocol after the mutual consensus nationwide. And then we all have to follow those protocols. I think that was the discussion yesterday in the PSA also. So yes, it's very important for countries like us that we should develop the protocols and follow them strictly. So that was all from my side. And thank you, Dr. Mujahid, for such a wonderful presentation. I must say you are a great teacher. Thank you.
Thank you, Dr. Fraz, for such nice words, and I am grateful.
Thank you to both of you. I'll request the participants to fill in the evaluation feedback so that the e-certificates can be generated to them. And lastly, I'd like to request Dr. Asma to culminate this lecture series on neuroanesthesia practices.
Thank you so much, Dr. Abdullah, for coordinating all the sessions. And here I would like to tell everyone that this module of neuroanesthesia, it was actually prepared by Dr. Faraz Shafiq, and we had invited him to make a whole module for you guys. So I really am also thankful to Dr. Faraz Shafiq for coordinating otherwise all of these topics in the program, which were really important because he's the lead in neuroanesthesia at ACU. And I'm grateful to Dr. Mujahidul Islam for such an exceptional talk because this is the core of our lecture series that we inculcate the latest literature and guidelines, and he has proved all of these in this topic today. So I wanted to also make another announcement that this module is ending. Today is the last lecture, but we will be starting our next module, which is on obstetric anesthesia, very soon. Because we were busy in the PSA conference, so we are still in the phase of making it, and hopefully we will be sharing the whole schedule with all of you in next 2 weeks time period. So please bear with us. We will not be present after 2 weeks, but definitely we will share the schedule in 2 weeks time so that we can start our presentations and our talks and modules from July onwards. So I'm really grateful to each one of you who has been participating very regularly in these lectures. And I'm equally grateful to Dr. Mujahid, Dr. Faraz Shafiq, and Dr. Abdullah for not only presenting this talk, but also coordinating whole of the session. So thank you, everyone. Thank you so much.
Thank you, Dr. Asma.
Thank you, everyone. And with this, we would be culminating and ending the lecture for today. As a reminder, please do fill in the link so that the certificates can be generated to you on your emails. Thank you very much.